What led you to the lab, and from there to infection prevention?
I initially started out in college wanting to be a pathologist, but things weren't working out on the road to med school. So I essentially tried to find a different program in which I could be as close to pathology as possible while not doing the med school route. And I found clinical laboratory science. So I went to my advisor and asked her all about it. And she said this would be a great route for you. And so I ended up graduating college with a degree in clinical laboratory science and became an ASCP certified medical technologist. I got started in a microbiology lab here at Froedtert Hospital. And I was very fortunate to be hired into this particular lab because we had a very forward-thinking, innovative medical director who was very interested in increasing the lab's technology. So in 2006, when I first started in the lab, we had just begun to start doing some molecular testing for all those microorganisms that we test for in the lab. But we're still mostly doing viral cultures and those sorts of things. And then my medical director eventually decided to start adding on all this technology in PCR and making it affordable to patients in the best way they could, at least, but also having much quicker results and more sensitive and specific results, depending on the bugs we're looking for. So I worked in the microbiology lab for about 10 years, did a lot of processing of specimens coming in from the hospital and from our outside clients, and then eventually got to learn the plate reading benches. I had a full immersion into molecular diagnostics, and then eventually became a supervisor of the second and third shift staff in the microbiology lab. And with that, I also got to learn how to do some research along with my medical director, who was big on doing validation studies and FDA approval type studies on novel technology that we're bringing in, and just got the full breadth of experience while I was in the lab. There were a couple of benches I didn't get to touch on, unfortunately, because working the off shifts, do every bench in the lab, at least not the one I worked in. But ultimately ended up, after about 10 years, trying to, figure out what can I do next. Because the one thing about working in the lab is you're kind of away from patients, and some people really like that, but others kind of want to be a little bit closer, and that included me. So I ended up looking around, and then my medical director actually told me that he was approached by one of his colleagues in the infectious disease department asking if there were any med techs who might be interested in infection prevention and control. And he told me about it, and I was just like, yeah, I'll look into it. I interviewed for it, and the person interviewing me, who's the director of infection control at the time, was very interested in me, and we ended up hiring me, and I've been in this position now for about 6 years.
Can you describe a day in the life in infection prevention?
I come in to work, and I immediately have to do what we call infection surveillance and isolation surveillance. So Froedtert Hospital is about 600 plus bed hospital. There's 6 infection preventionists on the team, and we are each allotted certain parts of the hospital that we have to cover. So I have the medicine department is essentially, I have 5 or 6 patient care units that I oversee for surveillance. So I'm looking for, anytime there's a positive lab that came back that would require a patient to be in isolation, say an antibiotic resistant organism or something, I have to make sure that patient gets into isolation. So staff are wearing a heightened level of PPE than they normally would for a patient without needing isolation. So I have to make sure that the chart is updated with all of those pieces whenever I find them. And then I also end up doing what we call hospital-acquired infection surveillance. So the big ones are central lines for bloodstream infections and catheter-associated urinary tract infections. So those are the 2 big ones we do in a hospital. Most of your devices are going to be your Foley catheters and your central line for bloodstream infections. And then we also have a lot of ventilators too. Even before COVID, you have a lot of patients in ICUs who do require ventilation, and we do surveillance for ventilation associated pneumonias as well. So that's my first thing I do. I do a lot of our department is very much a collaborator with the nursing staff and the physician staff in the hospital. So answer a lot of questions that staff may have for us and work through a lot of the clinical pieces that patients might be facing. So another hospital-acquired infection we do surveillance for is Clostridium difficile, or C. diff, infections, because those are a big one in the hospital world in terms of antimicrobial stewardship, or and test stewardship, which is something I learned a lot about working in the lab, but then also as an IP, I'm very passionate about too, and I'm trying to understand the doctor's perspective of things, because from an infection preventionist standpoint, we're very much surveillance based. We have surveillance guidelines and requirements we have to do, but then there's also always a clinical piece, which is a little bit more gray. It's not as black and white. So working with the staff who cares for the patient, from the doctor all the way down to even the EVS person who cleans the room, just working together to figure out what the best move forward is for a particular patient, particularly in an instance where they have an infection that we require isolation for, or some sort of investigation for, as we would for a central line infection or a urinary catheter infection. We have a lot of meetings, planning meetings, and also review meetings to make sure that our processes are up to date, and that whatever we're using in order to, if we're doing an action plan to attack a particular problem, say we have in the last 3 months had a unit with a higher instance of C. diff infections than they had in the previous months. We have to do an action plan with the unit, which is the nursing and physician leadership there, to figure out what are some steps we can take to pursue getting this number to come back down to what's expected, or even below that, doing better than the industry standard in that case. I also do a lot of answering questions of microbiology, having that background from the lab. I've noticed that the work of the lab is not necessarily well known when it comes to the floor staff. When it comes to taking care of patients, especially directly, they don't necessarily know, particularly when it comes to like test collection, which, like, if you're collecting a swab for a wound, there's a certain technique you have to use to collect that, which some people aren't always aware of, and it's not a huge part of a nurse's education in some cases. And physicians too don't get a whole lot of exposure to microbiology in medical school. So I do a lot of that, and I've even helped educate my fellow IPs on some of the lab work that we used to do, and help them understand why they're seeing lab reports, saying a certain thing, or what the different antimicrobial sensitivity panel results mean, and things like that. Lastly, I also am the infection preventionist in my department who oversees construction projects. Funny enough, when I was in my interview to become an infection preventionist, my director asked me if I had any experience with construction, and the only thing I could say was that I remodeled the bathroom once. But she said that was enough. That's more than I have. So she hired me, and I got immersed into the world of hospital construction. And a big piece of that is making sure that wherever your construction site is in the hospital, being able to do a risk assessment and determining, okay, what's the risk to the patient population? So having the clinical background that I do makes me an important member of that construction team, in the sense that, if I'm doing construction in an OR where you have to have sterility, versus if I'm doing it in an office area, what are the differences and degrees of difficulty and things like that? And a big piece that we do is, in my profession, when it comes to construction, is monitor air quality around the containment of the construction site. And then also, and this is a newer thing in the hospital construction industry, but water management, and how are we ensuring that the water we're putting into if we're building a new plumbing system, or if we're tapping into a different part of the hospital's plumbing system to add water to this new space, is the water safe? And can our patients be assured that they're not going to get things like Legionella or coliform bacteria or any other kind of bacteria or fungus or mold, any of those things. We have to make sure our construction sites are safe and that our staff and our patients on the outside of that construction site are kept safe. And that also includes on the patients and the staff who will be working in that new space once it opens. So that's a big piece of my job too. That actually probably takes up more than half of my day personally.
Describe a day in the life in infection prevention. What lab skills have you found most valuable in infection prevention?
For me personally, it's knowing from the microbiology lab, you work the urines bench or you work the respiratory bench and all that, and knowing what the pathogens are and the, normal flora are. And then also having that background, because as a med tech, you learn a lot of pathology when you're in school going through the program. And it is technically, the lab is a pathology department. So you learn a lot about how all these little pieces of the puzzle interlock when we're talking about the patient's clinical picture and what their comorbidities might be and why they're in the hospital or why they're visiting the clinic and things like that, and mixing that with all the knowledge you gain from all of the microbial identification that you do across the board, whether it's viruses or bacteria or fungi and everything in between. But having that knowledge has helped me immensely. It's given me the ability to be able to read a patient's chart and their lab results and have a good idea of what I'm looking at. So for example, if I have a urine culture come back on a patient with a Foley catheter and I see a certain bug in there, that's the bug I'm kind of focused on, in the sense of when I have to do that action plan because we have, a urinary catheter related infection. That helps me from my perspective in that safety huddle that we do and that action plan of be like, okay, this looks like it could be a skin bug. How could this have gotten there on this patient if that's the only bug we're seeing in the culture? Or with bloodstream infections, from time to time, I'll see a bug that's a GI bug in that blood culture. And so one of the things that leads me to do is like, well, is this patient scratching their insertion site wherever that central line is placed, to see if maybe they're contaminating the line themselves. And that has been the case sometimes. I've had a couple of patients have those infections where they are not very compliant in their daily hygiene cares for a multitude of reasons. And sometimes also we'll pull at their lines and stuff because they're uncomfortable. We don't want all that stuff sticking in us. So some people can get really agitated and irritated and will start just contaminating those sites inadvertently just because the dressing itches or because the line is bugging them. And that's the same with catheters too, and even vents sometimes. Although vents are a little bit more of a closed system and we're a little bit more concerned about what's inside their lungs causing those infections. But having that knowledge too and background, I think, helps a lot. And then the other piece too, and you don't have to be a microbiologist in the lab to be a good IP. Just knowing the background of your clinical lab science education and being able to really problem solve and think through, and most importantly, recognize when something doesn't make sense. So one of my bosses in the lab told me, I can train you on how to read a result on a computer in about 2 seconds, but you have to learn how to think about how that result might not make sense and troubleshoot it. And that's part of what we do in infection control too, is kind of understanding, okay, I have all this data in front of me, but every once in a while you kind of have to step back and say, okay, what else could it be though? Because it's not all adding up. And that's an important thing that clinical laboratory science folks know really well. And it's something that's also very important to apply to my profession in infection prevention.
What's your favorite part of your work?
My favorite part of my work is I love doing the construction stuff. There was one time when I had first started as an infection preventionist and we were doing this huge project. We were building multiple floors on top of a building that already existed. And I'm out there in a hard hat standing on the roof, overlooking the city of Milwaukee off in the distance and just being like, this is something I never thought I'd do as a lab tech ever. So that was pretty cool. And it's also very interesting work. So for me, there's a lot of investigation and weekly rounding that goes into it, where you're learning all these different facets of a construction project that you might not know, but also learn how it ties into, okay, well, this phase of this project might be a good time for us to maybe have some mold exposure from the air coming from outside. Or if we're putting in a plumbing system, learning how we're going to disinfect that plumbing system, and being part of the team that determines what kind of disinfection you're going to do in that plumbing system based on the bugs you would want to definitely prevent from coming out of there, but then having that water system exposed to other things that are unknown further down the stream, particularly if you're in a area where your municipal water supply is not, the cleanest. Not to say that municipal water supplies aren't clean, but you don't know how much disinfection they're necessarily putting into their system unless you call them up and ask, and then you figure out how much you're getting by the time it reaches your building through all those city streets. Or if you're in rural areas too, that's also a concern. But those kind of things I've found very interesting and have really enjoyed doing. And then another thing I really like is overseeing compounding pharmacies. Compounding pharmacies remind me a lot of parts of the microbiology lab, where you're working in negative pressure rooms and places that are very stale to avoid contamination. And when you're doing IV sterile compounding of drugs, you have to have a lot of the same technique in the hood, in terms of how are you going to make sure that ensure this drug's sterility before you give it to a patient. We put it in their IV line, and also just they're interesting people to work with too. I grew up with a parent who's a pharmacy tech, so working with them, now in this job and having just an ancillary background knowledge of it, but getting to learn more of it has been really interesting for me. And then lastly, one of my units specializes in cystic fibrosis patients. So I've gotten to learn a lot about cystic fibrosis. I personally have not been touched by cystic fibrosis in myself or my immediate family, so I've gotten to learn more about it as an adult, but particularly going along the lines of my experience with antimicrobial stewardship in CF patients who have a very specific type of lung flora they have, and having done CF cultures in the lab too helped with this, but understanding more about how we care for those patients, so they're not just bacteria on a plate, but how we interact with those patients and do different isolation precautions to make sure that those CF patients are not exposed to a bug that their system wouldn't be able to necessarily handle the same way yours or mine would, has been a very interesting kind of journey for me as well, and something I've thoroughly enjoyed.
What one key thing would you like to share about what you do?
I would just like them to know that they have the skills to be able to do this really well. I think my team, like I said, we have 3 former lab techs on our team, and we have 3 nurses on our team, and all of us have a different background. One of my colleagues, who's an IP, worked in the microbiology lab with me, but she did a lot of different stuff than I did when we were in the lab together. Another one of my colleagues is a PhD in immunology, but she has been able to make really good inroads with some of her background as well. And then we have an ICU nurse, an OR nurse, and a regular medicine floor nurse too. So all of these different backgrounds, and it's also given me the ability to kind of teach the lab piece to people, which just helps further, the lab world's, coming out of the, the basement of the lab, if you will, and getting other staff in the hospital to really understand and respect the work that we do in the lab all the time. But our backgrounds too also make it easier for us to kind of learn some of those nursing pieces. I didn't know anything about a central line before I became an IP, but I got to learn. I have nursing colleagues who taught me, and getting to understand how those types of devices work also helps me then be a better infection preventionist. But having the background and what's going on inside the body from being part of the lab also then helps understand some of those devices and all the other things we use to care for patients on the floors. So I would also say too, traditionally infection prevention is thought of as mostly a nursing profession, and largely your managers, directors, and VPs are usually nurses. But there's starting to be a lot more appreciation for med techs in the field of infection prevention and that background, and people are kind of starting to come around. So I know back in the day when I was looking at job descriptions to try to get an IP job, it was always bachelor in nursing minimum, but then slowly we were able to work around that, and they're building multi-diverse teams of professional backgrounds for those. So I mean, any IP who wants to get involved more in, or any lab tech who wants to get involved more in patient care, like more direct patient care, you're still not taking care of the patient at the bedside, but having more interaction with the way that healthcare is provided, particularly in hospitals, it's a great avenue to go.